think they've done a really good job, actually. It's quite a challenge, I think, to condense all that wealth of data that we've collected over the last few years on cardiovascular outcome trials. I can see that they've really focused on the type of population as well that was studied in those trials, so looking at patients with established cardiovascular disease. And I think what's really helpful from a primary care perspective is putting that right at the top of the sort of guideline and focusing the minds of clinicians at a very early stage of whether a patient has established cardiovascular disease or not, and then kind of helping them and leading them through the process of which agents may be beneficial in those patients, but not ignoring the other aspects that are important in the management of type 2 diabetes, so looking at patient-centered approaches, other complications and other comorbidities outside cardiovascular disease. Yes, I found the decision tree quite useful. I think one of the main questions that keeps on cropping up in primary care that I come across anyway, speaking amongst colleagues, is knowing which agent to use and when. And I think this guideline does address that. Still very much looking at class of agents here as opposed to individual agents. I think that debate is probably going to continue for a little while longer, and I think the difficulty that we have is, the trials that have been reported so far are looking at quite different populations and of different criteria as well. So I feel that will still be an ongoing debate and question in primary care of which particular agent to use within the class. But I think the decision-making tree is very helpful. I think it focuses the mind of the clinician, and particularly with two agents which perhaps in primary care aren't prescribed as often as other agents, as the more traditional agents. I think this will be very helpful actually, and really bring cardiovascular risk right to the forefront of the primary care clinician's mind. I think so. One of the things I quite like about the ADA EASD kind of joint statements and consensus reports is that they do have a focus on a patient-centered approach. Although that may not always translate to local guidelines, it's a nice reference point, and I think they've really built on that from their last consensus report. Really looking at areas of weight loss, hypo risk. Again, it's a case, I feel, of focusing the mind of the primary care clinician within a 10-15 minute appointment. Trying to prioritize different things can be difficult, and obviously the patient will have their own agenda as well. So I think the guideline helps in terms of making those priorities at an early stage and discussing them with patients and ensuring that they're addressed appropriately and in an appropriate time as well. I thought it was quite interesting actually. I noticed that I saw that there was recommendation in terms of non-surgical and surgical interventions for weight loss. I saw reference to 15 kilos of weight loss, perhaps leading to remission in patients with type 2 diabetes at an earlier stage of disease. So I thought that was quite nice because, again, they've tried to encompass as much of the recent data that we've been seeing, from, in that case, the direct study, but it again just highlights how they really have tried to attempt to include as much of the data that we've been presented with over the last couple of years, which is not easy, and I know is an area often of confusion in primary care. So I think it was nice to see that in lifestyle management as well, which is often an area that does get neglected. We do tend to become quite therapeutic focused, so that was quite nice actually to see that and see it being highlighted in that way. One of the challenges I think we have with these sorts of guidelines or consensus reports, particularly when we're looking at the diagrammatic illustrations that they have, it seems to almost go in a very chronological order, but we don't see that in primary care. We have patients who may have had the condition for 15, 20 years. So I feel that some work needs to be done in future consensus reports, looking at patients who may not be going through that process of monotherapy, dual therapy, and in the way that it's illustrated in the reports. So I think that's an area of development, certainly. Another area I feel that needs some more attention is de-escalation of therapy as well. And although in the article that's been published, that's been discussed, again, most clinicians that I know will be looking at the illustrations and the schematics. And as far as I can recall, that really hasn't been looked at. And I think that's a real area of importance. Medical therapies that may not be effective in certain patients, therapeutic options that may be causing hypo risk. Those are both areas where we need to consider de-escalation, and this is an area of growing interest as well and importance, and I think that's something that we may need to have developed in future guidelines, and certainly I'd like to see that going forwards.